You're going to see it. Patients will be perhaps unwilling to talk to you about it, but you're going to see it. Okay? All right. So, some terms first. Not directly related to erectile dysfunction, but related to sexual dysfunction in general. So, anejaculation, loss of seminal emission. Okay, so anything that causes loss of seminal emission can cause anejaculation. Okay. Often seen in spinal cord injuries. So you can have a patient who might still be capable of erections, still has normal orgasms as far as like sensation is concerned, but they don't have any emissions. Another place that you can see this, remember when we talked about testis cancer, I talked about people who have metastatic testis cancer potentially end up having to have a retroperitoneal lymph node dissection. One of the things that can be injured during a retroperitoneal lymph node dissection is the sympathetic nerves that run along the course of the aorta and the vena cava, and so they can end up unable to ejaculate. And this is important because what's the prime age range for development of testis cancer? 15 to 35, right? Prime reproductive years. So those patients can end up needing reproductive assistance, which we'll talk about on Thursday. So on Thursday, we're going to talk about incontinence and infertility, and those will be our last two lectures before the review on Friday. Retrograde ejaculation. So ejaculation is still taking place, but instead of the ejaculate coming out the end of the urethra, it's going backwards up into the bladder. We talked about that briefly when we were talking about alpha blockers for BPH, because when you relax the smooth muscle fibers in the prostate, there's also some smooth muscle fibers in the bladder neck that get relaxed, and if the bladder neck can't close, then the path of least resistance for ejaculate is backwards up into the bladder, and the semen just mixes with the urine and comes out the next time the patient urinates. Okay? Again, potentially a problem for reproduction. Retrograde ejaculation can also occur after something like a transurethral resection of the prostate, because you've removed that backstop. Okay? This is also why it's, well, not also why, but this is related to the fact why it's very challenging, nearly impossible for someone to urinate while they have an erection, because the bladder neck closes in preparation for ejaculation. And then premature ejaculation, distressful recurrent ejaculation with minimal stimulation before a person desires. So, who thinks that there is a textbook definition for what constitutes an intravaginal latency that is too short, meaning the period of time from penetration to ejaculation? Okay, based on the way I asked the question, you should be saying, yes, there must be a textbook definition. Okay? Anybody care to take a guess how long is considered a normal intravaginal latency period? I think I heard 25 seconds. 10 seconds. Let's go up a little bit. Okay, keep going up. 2 minutes. 2 minutes is the correct answer. So technically speaking, a normal intravaginal latency period is anything longer than 2 minutes. However, It's also subjective. So note the first part of the definition, distressful, okay? So if you have a patient who's normally accustomed to lasting longer than 2 minutes, and suddenly they don't last longer than 2 minutes, that's distressful. If you have somebody who's used to lasting 30 minutes, and now they're only lasting 10, that could be distressful for them, so it's subjective. What it really boils down to, as far as what's considered a normal intravaginal latency period, is a period of time that is satisfactory for both partners, because it can be distressful for both individuals involved, okay? But the textbook definition is 2 minutes. There are no questions on the exam about that, but it's something important for you to know, because you're gonna see these patients. You're gonna have patients that come in that are distressed by their sexual health and their sexual function, okay? All right, so erectile anatomy, we won't spend a lot of time on this. Hopefully this is a review, but so you see this is a section through the penis. You've got the corpora cavernosa on the dorsal aspect and the corpus spongiosum on the ventral aspect. And you notice, as we talked about before, the two corporal bodies communicate, okay, which is why you can administer injectable medications for erectile dysfunction in just one location, and you don't have to worry about only half the penis becoming erect, because they do communicate. It's also why you can irrigate with somebody who has priapism, and you only have to irrigate on one side, okay? All right, so did y'all ever learn the mnemonic point and shoot? Parasympathetics are responsible for erection. Sympathetics are responsible for ejaculation. Point and shoot, okay? So neurotransmitters released from the cavernous nerve terminals from the endothelial cells in the penis results in smooth muscle relaxation in the arteries and the arterioles, which increases blood supply, and then the sinusoidal smooth muscles within the paired corporal bodies relax, which allows for expansion of the sinusoidal system, which causes an erection. Okay. And then the venous plexus between the sinusoids compress, results in occlusion of venous outflow. So what really causes an erection is, so yes, there is an increase of blood flow to the area, but it's this restriction of blood flow on the way out that really what causes a rigid erection, okay? And then detumescence, or loss of the erection, results when the neurotransmitters release, or the release stops rather. And then phosphodiesterases break down the second messengers, which is why the medications that are most commonly used today to treat erectile dysfunction are phosphodiesterase inhibitors, okay? Inhibits the breakdown of phosphodiesterase. And then sympathetic discharge leading to ejaculation also propagates the detumescence. Okay? All right, so you can see here a comparison between flaccid anatomy and erect anatomy. So the corpus spongiosum also becomes engorged with blood during erection, but it is not a structure that is necessary for the structural rigidity of the erection. The reason that the corpus spongiosum becomes engorged is to keep the urethra patent, because if it was just the corporal bodies that became engorged, the urethra would become compressed, and then ejaculate would have a much harder time getting out. So having the corpus spongiosum become engorged facilitates ejaculate getting to the outside. Okay? So, parasympathetic nerves point. Okay? Another way to remember it is feed and breed, right? Because parasympathetics also play a role in digestion, feed and breed. And then the pudendal nerve is responsible for penile and clitoral sensation, which is why people who are long-distance cyclists or competitive horseback riders or what have you can have problems with saddle paresthesias and paresthesias into the genitals because they're compressing their pudendal nerve from sitting on it. Okay. Nitric oxide is the main neurotransmitter for initiating and sustaining erection. This is what phosphodiesterase inhibitors prevent from being broken down as nitric oxide. So when you give somebody a PDE inhibitor, the concentration of nitric oxide goes up and stays up because it hasn't been degraded. Okay. Others that are involved include acetylcholine, prostaglandins, VIP, but the main one is nitric oxide. Okay. Here's that in graphic form. You see phosphodiesterase circled here. Block that, and patient's erection, they're either able to achieve one or their erection doesn't go away. Okay. Do phosphodiesterase inhibitors help address premature ejaculation? No, they do not. Okay, so the definition of erectile dysfunction: consistent inability to attain and or maintain a sufficiently rigid penile erection for sexual performance. So it's either it doesn't get hard or it gets hard and doesn't stay hard. Okay, either one of those is erectile dysfunction. Okay. We've talked about this before. Most common cause is a decrease in arterial flow from progressive vascular disease. So remember, if you have somebody who has hyperlipidemia, someone who has diabetes, if they're not talking to you about the quality of their erections, it's probably not a bad question to just ask, how are your erections? Because if they are having an issue with erectile dysfunction, that can be a sign to you that there's something potentially going to be going on with their other small vessels, like their coronary arteries. Okay. Between the ages of 40 and 70, the incidence is greater than 50% of men in that age range. Okay? Something to look forward to. And it can be organic or psychogenic. In your younger population, it's usually psychogenic, unless they have a history of trauma. Or if you've got somebody who's been a lifelong type 1 diabetic, for example. And you can have an overlap of the two, because if they have an organic problem that's causing some minor degradation in their erectile quality, and it starts to make them anxious, and they're worried about their ability to perform, now they've got a psychogenic component that can compound the problem and make it even more challenging for them to achieve or maintain an erection. How do you differentiate between the two? If it's psychogenic, they usually have intact nocturnal erections. So asking a patient if they ever wake up with an erection is helpful. Because if the answer is yes, if they wake up with a rigid erection, then that probably means that organically they're intact. And we'll talk a little bit later on ways you can actually test for that. Okay. Generalized means that they have a generalized inability to achieve or maintain an erection. Okay? It's not situationally based. And then situational, so partner related. So this is an important note as we go forward talking about medication for erectile dysfunction. PDE5 inhibitors are not magic bullets. Okay? Now, if you give a PDE5 inhibitor to an 18-year-old, they're probably going to be harder than Chinese geometry, okay? Without any stimulation. Give them medication and it works, okay? But in an older patient, or a patient who actually has an organic reason for having erectile dysfunction, if they're not interested in having sex with the person that they're with, it's probably not going to work very well. That baseline desire has to be present, okay? unless they're organically intact, in which case they don't need ED meds. Right? Performance related, talked about that just a second ago. So if they have anxiety because they had a bad night, then that can develop or result in the development of psychogenic ED. Okay? And then psychological distresses, so work-related stress. Any stress, sick child, any of these things weighing on somebody's mind can potentially have an impact on their erectile function. Okay? So you can see that sort of spelled out a little bit more specifically here. Okay? All right, organic, nocturnal erection, no. So they don't wake up with spontaneous erections. Another way to think about it is the embarrassing erection at inopportune times. Time for you to get up and do a math problem at the board. You don't want to get out of your desk because somebody decided that they were going to be awake that morning. Okay, common complaint in teenage boys. Okay. Normal physiology, right? But not necessarily convenient. Okay. So neurogenic problems, so think spinal cord injuries, hormonal problems. So testosterone does not have any direct impact on erectile function. What I mean by that is testosterone is not involved in the hormonal or neurologic cascade that causes erections. But it does have a significant impact on libido. When I'm explaining this to patients, I tell them it's the wanna. Okay? If you don't have a normal level of wanna, if you don't want to do it, then things aren't going to work as well. Okay? Arterial, right? So hyperlipidemia, diabetes, anything causing vascular compromise, trauma. If they have an issue with the venous outflow restriction, so if they've got normal arterial inflow, but that venous restriction isn't happening the way it's supposed to, then it isn't going to work, right? And then drug-induced, right? So we all know that there's medications that can potentially cause erectile dysfunction as a side effect, right? Psychiatric and behavioral health meds are a key culprit here. But blood pressure medicines can have an effect as well. Right? If you're lowering somebody's blood pressure because they're hypertensive, it can potentially have an effect on their ability to achieve and maintain erections as well. Okay. And then as you see here, the mixed picture is the most common. As I've already mentioned, vicious cycle, right? Little bit of organic problem results in some poor performance. Now they start worrying about whether or not that's going to happen again, and the cycle propagates itself. Right, so here you go. Here's some more details on conditions that can cause those various underlying causes, right? Any questions on that? All right, so males greater than 40. All of these things we've already talked about: diabetes, dyslipidemia, hypertension, psychological conditions, tobacco and alcohol, recreational drug use. Recreational drug use can also, as we've already talked about, cause the opposite problem, right? Cocaine can cause priapism. Previous prostate cancer treatment, why would that have an effect on erectile function? Say again? So radiation, yep. But why? What's the mechanism? So you're right, pelvic radiation, surgery.
Scar tissue?
So it's not scar tissue. So, nope. Good thought, but no. Maybe, but not directly. So the reason that previous prostate cancer treatment can have an effect on erectile function is because the parasympathetic nerves, at least a portion of them that are responsible for erectile function, actually travel through the connective tissue on the anterior surface of the prostate. So if the prostate's been irradiated, I guarantee you the radiation has passed through that area. If they've had their prostate removed, then there's a chance that those nerves may have been damaged. Now, we've gotten better about that, meaning we know where those nerves are, and with modern surgical techniques, particularly robotic prostate surgery, we've gotten very, very good at doing what's called nerve-sparing prostatectomies to spare those nerves, okay? But even with a very meticulous dissection, it's still possible that those nerves can be injured. So if you have somebody who has a history of previous treatment for prostate cancer, be thinking erectile dysfunction, okay? They even do erectile rehab in people who are undergoing treatment for prostate cancer. They'll start them on scheduled PDE5 inhibitors before surgery and have them continue using them while they're recovering from surgery to help rehab those nerves and keep them functional. Okay. Thorough psychosocial and sexual histories are a must. Okay. Now we're getting back into that realm of uncomfortable questions. Right? These are important questions to ask. You need to know about their level of libido. Is it the same as it's always been? Has it changed? Is it specific to the partner that they're with? If they have no issues with the partner that they're with, think androgen deficiency, right? If they're happy in their relationship, if they had good sexual health before and it suddenly started to taper off and they notice that they're just not desiring sex as often as they were in the past, think androgen deficiency. Okay? Loss of seminal emissions, androgen deficiency, diabetes, history of pelvic or retroperitoneal surgery or radiation should be a fairly obvious piece of their history, but it may not be. Anorgasmia, so they have the ability to achieve an erection, but they have an inability to climax. These are things you need to know about. And then problems with premature ejaculation. Do they have any history of sexual abuse or trauma? What's the onset of their ED? Is it chronic? Is it every time? Is it just occasional? Is it situational? Okay. And is their problem achieving or maintaining? All things you need to be asking about when you're working somebody up for ED. And then obviously ask about these specific risk factors. Review their meds. Their meds might be the culprit. Now that doesn't necessarily mean that you're going to have to change their medication. They may be on something that they need to be on, but that doesn't mean that you can't treat their erectile dysfunction. Okay? So as I mentioned, antihypertensive agents, some antihistamines can potentially have an effect, and then antihistamines are a major culprit. Opioids, so if you have somebody who's got issues with chronic pain, the chronic pain may be an underlying factor in and of itself if it's causing depression and anxiety because they hurt all the time. But if they're taking opioids to manage their chronic pain, that compounds the problem. Okay? And then prostate agents. Again, these cause a lowering of blood pressure, at least initially, right, until tachyphylaxis develops, but they can continue to cause retrograde ejaculation, even after the tachyphylaxis for blood pressure has occurred. Okay. There are standardized questionnaires that you can use. At BAMC, every patient who comes into the urology clinic is given one of these questionnaires every time they come in, males. Okay. The SHIM inventory is the one that's used at BAMC. Okay. So every male that comes into the clinic as part of their intake paperwork is given both an IPSS scale and a SHIM. Some patients choose not to complete it if that's not the reason that they're there, but every patient is provided one. And these are validated questionnaires, so they result in standardized scores that give you objective data regarding the severity of their symptoms. Okay. And if you give one to a patient at follow-up, after you've made some intervention, it gives you some idea whether or not your intervention was effective. And if so, how much. And if not, how little? So this is what a shim looks like. How do you rate your confidence you can get and keep an erection? When you have erections with sexual stimulation, how often were your erections hard enough for penetration? During intercourse, how often were you able to maintain your erection after penetration? During intercourse, how difficult was it to maintain? And when you attempted sexual intercourse, how often was it satisfactory for you? You'll be surprised at the number of patients that answer like the first 4 questions on the very low end of the spectrum, but still answer number 5 with a 5. A little hard to explain. So even if so don't just jump to question 5 and say, oh, almost always or always satisfactory, because this may be an emotional component for them and not really a functional physiologic component. They may have significant issues with erectile function, but still find their amorous activities to be satisfactory. Okay? And also remember that this questionnaire is only for the patient who's being treated, right? It doesn't tell you anything about how satisfied their partner is. And that can be a significant factor to take into consideration. Okay, so on physical exam. Note their secondary sexual characteristics. Okay. If somebody's got gynecomastia, does that tell you that there might be something hormonally going on with the patient that could have an impact on their erectile function?
Yes.
It could certainly have an impact on their libido, right? If they're already overweight or obese and they're converting all their testosterone into estrogen, then that may have an effect on their libido. But if they also have a pituitary reason to be developing gynecomastia, that's something you want to figure out, right? If somebody has a prolactinoma, that potentially needs to be treated. Peripheral vascular and focused neurosensory exam, you're looking for signs of paresthesias. I'm not asking you to check like vibratory sensation or 2-point fine motor sensation on the penis, but that is something you can do if you're really concerned about it. Especially if they don't have any peripheral signs, but you still have reason to suspect that there's something going on locally. Like again, think like pudendal nerve paresthesia. Okay. And then specifically looking at their genital exam, look for penile scars, plaques, signs that may be an indicator of Peyronie's disease, because people with Peyronie's can have erectile dysfunction. And then look at their testicles. Make sure they feel normal, make sure they're of normal consistency and size. Okay? And then a prostate exam. Who saw the PSA commercial during the Super Bowl? Anybody see it? Yeah, I was really surprised. So for those of you who didn't see it, Bruce Arians, the head coach for the Tampa Bay Buccaneers, or former head coach for the Tampa Bay Buccaneers, did a public service announcement for PSA testing for prostate cancer screening. And it was funny, it was him and Gronk. And what position does Gronkowski play, or did Gronkowski play? Tight end, right? So the joke was, relax, Gronk, it's just a blood test. What did I always tell you, Gronk, as a coach? Oh, you gotta, I can't remember exactly what they said in the commercial, but it was something about like relax your buttocks, right? It zoomed in on Gronk's butt and he relaxed. It's just a blood test. Nobody's gonna stick a finger up your butt, okay? But prostate exam can be important when you're talking about evaluation for erectile dysfunction. Okay? Basic labs, right? Things that you would get for any other potential well person check, right? So CBC, BNP, UA, blood sugar. Maybe get an A1C if you already know that they're diabetic. And then testosterone, prolactin, TSH. You don't necessarily have to get a testosterone, prolactin, and TSH as part of the initial workup, especially if you suspect that the patient's problem is psychogenic, right? If it's a young patient, physical exam's normal, they relate to you a history of having a bad night and now they have problems performing every time they try, you don't necessarily have to get these. Okay? But if you have reasons to suspect that they're abnormal, by all means get them. Or if you've made some intervention and things didn't improve, then get them. Again, testosterone doesn't have a direct effect on erectile function, but it has a significant effect on libido. Thyroid stimulating hormone, if somebody's hypothyroid, that can have an impact. Okay. Now, for testosterone, for measuring testosterone for purposes of testosterone deficiency or hypogonadism, you technically need 2 early morning total testosterone measurements. Why? Why do you need to get 2?
Waxes and wanes?
Say again?
Like waxes and wanes, doesn't it?
So it does wax and wane. That is true. So your testosterone levels follow your circadian rhythms. So if you check somebody's testosterone every hour on the hour over a regular day, you would see that there's a peak early in the morning, and then it tapers off during the day, and then it peaks again at night. The labs aren't open at night most of the time, so early in the morning is when you're going to be checking this testosterone. So you tell patients to show up for their blood draw as soon as the lab opens. Okay. The other reason that you want to get 2 of them is because lots of things can cause abnormalities in testosterone levels. So if a person was recently ill, if they had some just very mild viral, say upper respiratory infection, then that can have an impact on their testosterone levels. Okay? If they had the flu or they were really sick, then their testosterone levels are really going to be out of whack until they get back into physiologic homeostasis. Okay, so you want to get 2 of them, because one abnormal level doesn't necessarily tell you that they have a constant abnormal level. Okay? And then if their total testosterone is abnormal, then get a free testosterone and a luteinizing hormone to help you differentiate between a primary testicular problem or a central problem in the hypothalamus or the pituitary. Okay. Specialized testing. If they don't fit the expected clinical picture, then you might need to do some specialized testing. Okay? If they're young and it doesn't look psychogenic, if they have a strong family history of cardiac disease, dad died at age 40, grandpa died at age 40 of heart attacks, look into that. History of pelvic trauma, if they've already failed conservative management, if it's likely primary psychogenic, we'll talk about this a little bit more. You don't necessarily have to do specialized testing. Oftentimes just giving them a prescription for Viagra will solve that problem. We'll talk about that in a second. Okay. And if they've had lifelong ED, they've never had normal erectile function. Okay. You should only use specialized tests that we're getting ready to talk about if it'll affect management. Okay. So, you'll understand why when you look at this. Nocturnal penile tumescence testing. You think we do this on everybody who comes in saying, I don't have very good erections? No. But if they can't tell you whether or not they have nocturnal erections, and you want to know for sure, are they having nocturnal erections, then you can do nocturnal penile tumescence testing. So as you can see, there's a cuff that goes around the shaft of the penis, and then the measuring device is secured to the thigh in a pouch with straps, and it just detects penile tumescence overnight. And then it prints it out on a graph for you. Shows you how frequently they were having them, how significant were they, how much pressure was being generated. Okay. I have never done this. I have never ordered nocturnal penile tumescence testing on a patient, but it exists. Okay. Another thing you can do is you can inject them with prostaglandin E1 in clinic and see if it gives them a normal erection. If it does, then they are vascularly intact. And it rules out an organic cause. Practically speaking, do we just jump to this? It's on the slide. No. Most patients are put off by the idea of being stabbed in the penis with a needle, or the idea of having to do it to themselves in order to have normal erectile function, which is why the injectable medications have sort of fallen out of vogue with the advent of PDE5 inhibitors. Viagra is effective in 80% of patients that take it. And it doesn't require a needle. And so why put them through the trauma of this when you can just give them a trial prescription of Viagra and say, come back and see me in a couple months, let me know how it worked out. Doppler ultrasound of the penis. Another way to evaluate for penile blood flow. You really need an ultrasonographer who is experienced in doing Doppler ultrasound of the penis, which you may not have if you're in a small facility. Hopefully, if you're in a large facility like a very large community hospital or a medical center, they'll have somebody in the radiology department who's skilled at doing this. Another reason why it's not done super frequently. All right, so here's the algorithm. You can see here various options for treatment: PDE5 inhibitors, vacuum devices. We've seen the movie Austin Powers. My Swedish Penis Enlarging Pump and Me by Austin Powers. This really is my bag, baby. That's what we're talking about when we talk about vacuum devices. Okay. Intraurethral alprostadil. This is on formulary for the DoD. Okay. It's called Muse. It's the brand name. You can look it up in the ordering system if you're ordering medications for a patient. So it's the same alprostadil that's used in intracavernosal injections, but it's a pellet. I think I have a picture of it later on. It's smaller than a grain of rice. It has a special applicator that's about 3.5 centimeters long that's inserted into the urethra through the meatus. You push a button on it and it deploys the pellet, and then the alprostadil gets absorbed through the mucosa of the urethra, and then through that vascular circulation gets into the corpora cavernosa and causes an erection. There's some patients that really, really like it. Patients who've been on it for a long time and won't use anything else. Okay. It's a good option if they failed PDE5 inhibitors and they're squeamish about injecting themselves. And then intracavernosal injections, and then penile prosthesis surgery is your last resort. Okay. All right, so as with everything else we've talked about and everything else you talk about in any healthcare class, lifestyle modification, reduction in risk factors, control their dyslipidemia, control their blood sugars, control their hypertension, quit smoking, reduce alcohol intake, all that good stuff, okay? And then discontinuation of offending medications if possible. As I've already said, they may be on something that they need to be on. You don't want to tell somebody to stop taking their antidepressant just willy-nilly because they have erectile dysfunction. That requires some careful thought and probably involvement of their behavioral health provider if they have one, if they're not getting their behavioral health meds from you. Okay. I think I mentioned this before. We actually had a psychologist embedded in the urology clinic at BAMC when I was there as full-time faculty. So we would utilize that person for anybody that we thought needed behavioral health intervention for something related to urologic health. So erectile dysfunction, if they had a new diagnosis of cancer, we would have them see our psychologist. Okay, it can be very, very helpful, especially if it's true psychogenic or mixed. Okay. And you can see what the AUA's guidance statement is regarding behavioral health referrals. It is supported. You can see here from a study that was done in 2007, Viagra only versus Viagra with couples CBT, cognitive behavioral therapy. and be careful here, CBT has more than one meaning when it comes to sexual health. I mention this not to be crass, but because I've actually seen this happen and cause confusion. So our psychologist went to a sexual health symposium and was talking with one of the vendors there who had a flyer that talked about all the different services that they offered. This person was not a behavioral health professional. This vendor was not a behavioral health professional, and listed on their flyer was CBT. And our psychologist thought that was very interesting that they provided cognitive behavioral therapy, wondered how they received training and how to do that since they weren't a behavioral health professional. It meant cock and ball torture. Okay? All right? So I bring that up to say if a patient tells you that they've been getting CBT, make sure you know what CBT they're talking about. Okay? It might be cognitive behavioral therapy. It might be something else. Okay? But combined therapy had better outcomes. Okay? All right, so PDE5 inhibitors, game changer. Right? When Viagra was discovered, it became the most prescribed medication in the United States for a while. Okay? The single most commonly written prescription. 80% efficacy in patients that take it. It's non-invasive, it doesn't cause pain, they don't have to do anything uncomfortable for themselves to make it work, to administer it, okay? And now we have quite a bit more medications in that class. So Viagra was the first, okay? Tadalafil we've talked about before, that's your Cialis, right? Vardenafil is Levitra. And then Avanafil is the newest, that's Stendra. Okay, brand name is Stendra. So sildenafil and vardenafil are basically the same as far as half-life, time of onset, that sort of thing. So your tadalafil and your Avanafil are the ones that are different. So we talked about tadalafil before, it has a half-life of 36 hours, which allows patients to have some spontaneity. They could take their tadalafil at 8 o'clock in the morning, and by noon the next day, they still have therapeutic levels in their bloodstream. Avanafil's claim to fame is its onset. So for all the other three, you need about an hour after ingestion before you get physiologically effective levels. Avanafil, 15 minutes. So if you've seen commercials, primarily on the internet, I don't think I've seen any commercials on television, but if you've seen commercials like, say, on YouTube, for example, for like Rose Sparks is an example. It's a mail order pharmacy service, okay? They say, works fast but lasts long. It's compounded. It's a combination of Avanafil and tadalafil. So rapid onset and then prolonged mechanism of action. Okay? You won't find that combination in a pill that you can prescribe because it's compounded by a specialty pharmacy. Two different manufacturers, two different patent holders, they're not working together. But a pharmacist can combine meds if they want to. So a compounding pharmacy has the ability to do that. Okay. Change in sexual health scores from pre-treatment baseline to post, looking at all these different meds. As you can see, there's a fairly normalized mean among the actual medications, and then placebo's up here at the top. So they all work, and they all work well. It's just they have different characteristics. All right, adverse effects, hypotension. So anytime you propagate the presence of nitric oxide, it causes vasodilation. So if they're already taking an antihypertensive, you just have to caution them. They shouldn't take them at the same time. Okay. nitroglycerin or other nitrate-containing medications. Relative contraindication. There are some people out there who just flat out won't give PDE5 inhibitors to patients that have a prescription for nitro. Okay? Even if you have a patient who says, well, they gave it to me because I had angina a few years ago, I've never taken it, I just carry the bottle around in case I need it. You probably don't want to be giving them a PDE5 inhibitor. What happens if you give somebody Viagra and they start having intercourse and they develop exertional angina? Well, now their options are just deal with the angina or take their nitro and potentially bottom out their blood pressure and lose consciousness, have a heart attack, have a stroke, right? So if they have a prescription for nitro, be very, very cautious about prescribing PDE5 inhibitors. And then your relative contraindications: active coronary ischemia, heart failure, borderline hypotension, cytochrome P450 inhibitors. Who knew that grapefruit juice was a cytochrome P450 inhibitor? You guys learned that yet? Yeah. Okay. Just something to be cautious about. Doesn't mean they can't have it, but caution patients. All right, so talked about sildenafil already. Onset 30 to 60 minutes. Duration says up to 12 hours based on half-life. Really, you're looking at an hour or 2, 3 of maximum effect in clinical application. Very important that patients take it on an empty stomach. Okay? Why? Why does it work better on an empty stomach?
Is it more like basic?
Say again? I can't hear you, I'm sorry.
More seated environment?
So it
Less
has nothing to
acidic?
do with the acid or base environment.
More blood going away from the stomach.
Good thought, but blood flow isn't the key.
Sympathetic
So
nervous system?
it has to do with bioavailability. All of the PDE5 inhibitor medications are fat soluble. So if they have a fatty meal in their stomach, then some of the medication will actually dissolve in the lipids and it becomes non-bioavailable. So you're actually decreasing the amount of medication that's actually available to the patient. So as a general rule, I tell people that if they're going to take any PDE5 inhibitor, it needs to be either an hour before or 3 hours after any meal. Okay, an hour before gives them time to digest it, get it out of the stomach, get it into circulation. 3 hours after allows a period of time for gastric emptying. Okay. And like I said before, stimulation needed for erection. It's not a magic bullet unless you're giving it to a neurologically, organically intact 18-year-old. Okay. All right, vardenafil, 20 milligrams. Real quick, go back here to Viagra for a second. So 50 to 100 milligrams. How many tablets of any ED med, any PDE5 inhibitor, will TRICARE authorize for a 90-day supply?
28?
6 tablets a month. So 18 for a 90-day supply. Okay? You will find that patients would like to have intercourse more than 18 times in a 90-day period. Give them 100 milligram tablets. Write the prescription for hundreds. Have them cut the tablets in half. Try a 50 milligram dose first. If it works, they just got twice as many pills. If the 50 milligram dose doesn't work, they can take the other 50, but don't exceed 100 milligrams total. It does not improve outcomes, but it does increase the likelihood of adverse effects, like hypotension. Okay? But give them the hundreds, tell them to cut it in half, because then you just doubled their supply. Okay? Same thing applies with vardenafil. Give them the 20s, have them cut them in half, try 10. Okay? Should not have patients cut their tadalafil. Okay, it already has such a long mechanism of action. especially if you're giving them tadalafil with the daily dosing, the 5 milligram daily dose for BPH with ED, they should just take it because they need to take it every day to reach that steady state. But if they're using it for on-demand, they're usually better off just taking the max dose because then it lasts for 36 hours. You'll have patients that try it anyway, cutting it in half. The other reason that cutting these tablets in half can be a little problematic is you notice the shape. So if you cut it in half this way, you're not getting an even cut. And trying to cut it in half from point to point is a little challenging. And then Stendra, as you can see, comes in a wide range of strengths 15 minutes before main claim to fame. Okay. Let's take a 10-minute break.
%.
Not anymore.
What?
There used to be. It used to be 20. So it used to be a 20% disability rating for erectile dysfunction. The VA has since determined that because erectile function does not impact your earning potential, it no longer warrants a disability rating. Now, that doesn't mean that patients can't get compensated for erectile dysfunction, but they have to be able to tie their erectile dysfunction to another compensable medical problem. So if they have depression that's service-connected, that causes them erectile dysfunction, then they can get something that's called SMCK, which is Special Medical Compensation, and I don't know what the K stands for. But it's like an extra $150 a month. It's not a huge amount, and it does require documentation that shows that one begat the other. But yeah, the days of the 20% disability rating for erectile dysfunction are over, at least for now. You know, obviously, these standards change from time to time. So, intracavernosal injection, right? So a question was asked at the break, are the contraindications the same as far as like nitrates are concerned? The answer is no. It does not have the same mechanism of action. As you can see, rather than having an impact on nitric oxide breakdown, it stimulates adenyl cyclase to increase cyclic AMP. Okay, so you still need to be cautious. You still need to let patients know that there's the potential for fluctuations in blood pressure, but you don't have to worry about the catastrophic hypotension that can occur with mixing PDE5 inhibitors and nitro. Okay. So this used to be the gold standard before Viagra was discovered, and it's still a great option for people that have failed Viagra. You'll find some patients who have been using this forever, and it's all they want to use. Okay. There is one brand name version of alprostadil called Edex that actually comes in a pre-measured syringe. Think like a insulin syringe for diabetes, so they don't have to draw it up. It's already self-contained, and all they have to do is inject themselves, and it gives them the right dose. But if you don't have access to it, if the pharmacy's out, if they don't carry it, what have you, you can write a patient for a vial and give them a supply of syringes, and they can do their own injections. So the injection should be done at about a 45-degree angle off of the dorsal midline. That way they're not going through the dorsal vein of the penis. Obviously, when I counsel patients that if they have a large vein that doesn't course just along the midline, don't go through the middle of it, even if it's at a 45-degree angle, go next to it, go around it. And the other thing you're missing here is the nerves that run along the dorsal aspect of the penis. So 45-degree angle off. In a lot of clinics, especially if they see a large number of patients with erectile dysfunction, you'll often have a nurse who's trained to teach patients how to inject themselves. If you don't, you have to do it yourself. So it's important for you to know how the injections are administered. Okay. There are other medications that can be used as injectables, but the only one that's FDA approved is alprostadil, which means to get Trimix or Bimix. So Trimix is alprostadil and papaverin, Bimix is alprostadil, papaverin, Trimix is all three of these. Bimix is just the first two, okay? To get that, you have to write a prescription for a patient to take to a compounding pharmacy. And in the city the size of San Antonio, there are several compounding pharmacies that can do this. If you're in a smaller community, you might not have any. Alprostadil works. Alprostadil combined with papaverin and phentolamine works really, really well. You have to be very careful to make sure that patients are given a correct dose, because if they use too much, priapism. Okay? So it's important anytime you start a patient on an injectable medication that you have them administer the first dose to themselves in clinic, because you want to make sure that their erection goes away in a timely fashion. Because if they wait and do it at home at 10 p.m. and overshoot the mark, then they're going to be in the emergency department getting their priapism taken care of. Okay? And chances are it's not going to be you that the ED calls to come take care of the patient's priapism. It's going to be the on-call urologist, and they're not going to be very happy. All right, so Muse.
Sir,
Yes.
the people that use the alprostadil, do they jump to the Trimix because they have tachyphylaxis, or do they start with the Trimix just because it's alprostadil doesn't work?
So usually people that end up on Trimix either got it from a men's health clinic that gives everyone Trimix, or they failed alprostadil by itself. It just didn't work. So it's not a question of tachyphylaxis. It's just the single agent by itself wasn't effective, and so they add additional agents on top. So same medication, again, it's alprostadil, but it's administered in a intraurethral pellet. So you can see the applicator here. DoD pharmacies do carry this. You can see how small it is, smaller than a grain of rice. Okay. One downside to, well, alprostadil and in all of its forms, whether it's injectable or whether it's Muse. So it's what class of chemical? What is it? It's a prostaglandin, right? So where does your body produce prostaglandins normally at baseline? It's inflammatory response, right?
Yeah.
If you have an inflammatory something taking place, trauma, illness, things of that nature, your body produces prostaglandins. So alprostadil can have some discomfort associated with it because of its very nature. So patients need to be cautioned about that, let them know that's potentially a problem. So obviously it's uncomfortable to have somebody inject themselves in their penis with a needle, but the level of discomfort that some patients experience can be disproportionate to the needle stick because of the fact that they're giving themselves a prostaglandin. Same thing applies here. Obviously, it's not super comfortable to insert a plastic tube into your urethra, but then the erection itself can be uncomfortable. That doesn't mean it's going to be uncomfortable for everybody, but they need to be cautioned about it. You need to let them know so they don't think there's something wrong. Like, oh, did I hurt myself putting this in because now my penis hurts really bad? Okay, and that can be mitigated with NSAIDs. Okay, if they are androgen deficient, you can give them testosterone replacement therapy, provided they don't have a contraindication like active prostate cancer. But again, remember, androgen replacement does not have a direct effect on erectile function. It's all about libido. So if their only problem is that they just have decreased sexual desire, and you correct it, then they may have return of normal erectile function. Just know that it's not a direct effect. All right, this is a relatively new product, as you can see, approved by the FDA in 23. Uroxon, available over the counter. Okay, it's a gel that's applied to the glands. It causes a cooling sensation. As you can see from the ingredient list here, there's no PDE5 inhibitor in it, there's no alprostadil in it. Ethanol, propylene glycol, glycerin, carbomer, potassium hydroxide. Okay. The evaporative action produces rapid cooling and then a gradual warming sensation, which increases blood flow. I have no information for you regarding efficacy, but it was approved by the FDA. So clearly it worked well enough for the FDA to give it a stamp of approval. All right, vacuum erection devices. Austin Powers. So, just having a vacuum pulling blood into the corporal bodies is not sufficient to cause an erection that maintains itself. You'll notice at the bottom of the picture here, there is an orange band. That is a rubber band. It is a special rubber band. It is purpose-built for this application. Patients should not use rubber bands that they bought at the grocery store for closing bread bags on their penis. Okay, not designed for that, not safe, potentially going to cause significant problems with blood flow, necrosis, that sort of thing. So you got to tell them that if they have a prescription for one of these. So these are actually handed out as durable medical equipment. So you have to write a DME prescription for these, and they'll get it delivered from a durable medical equipment company. But the way it works is they pump out the air in the cylinder, which causes a vacuum effect, which causes blood to come into the corporal bodies and the corpus spongiosum. And then they slide that rubber band off the bottom of the tube around the base of the shaft of the penis, and that keeps blood from leaving. The main complaint with these is actually from their partners, not from the patients themselves. What happens when you have decreased blood supply to an appendage? Temperature-wise, it gets cool, so it doesn't necessarily feel natural because now it's cold. Okay, so again, not usually a complaint that the patients have, but their partners may complain of that. Another issue with vacuum erection devices is that the patients need to have good hand strength and manual dexterity because the baseline pumps that most insurance companies will pay for are manual. So they have to pump it themselves to pump the air out. There are battery-powered assisted pumps, but not every insurance company will pay for those. So they might have to pay out of pocket. Okay. But while it says, men with these problems, it'll work on anybody, right? Simple physics. But generally, it's patients that have failed pharmacotherapy before you jump to a vacuum erection device. So here you can see the manual hand pump. Okay. Talks about the elastic ring. They need to use the ring that comes with the pump, not something they found at the house. And your final treatment option, which y'all aren't going to put in, but you need to know they exist, is an inflatable penile implant. Okay? Now, the earliest penile prosthetics were not inflatable. They were semi-rigid. So I'm probably going to be dating myself by asking this question, but who remembers the cartoon Gumby? Okay, I've got some hands. Who remembers the Gumby dolls that were sold in toy stores as part of the cartoon? They were rubber, right? And you could bend Gumby into all sorts of positions and he would stay there because there were wires in the doll, okay? So that's what and I'm oversimplifying things, but that's what the original semi-rigid prosthetics were. So it was these cylinders, just the cylinder component, no pump, and they were made of medical grade silicone rubber, and they had flexible armature is really the best descriptive term, inside, but they were always rigid. And so when the patient wanted to have intercourse, they just bent it straight. And when they didn't, they just folded it down. Okay? So convenient, not natural from a physiologic function standpoint, we do still use the semi-rigid prosthetics for patients who have poor manual dexterity and can't actuate the pump, because these are manually inflated. You have to be able to squeeze the pump mechanism with your hands. Another place that we use them is spinal cord patients who use condom catheters instead of urethral Foleys. Who's heard of a condom catheter before? Okay, I've got some hands. So a condom catheter is think of a condom, okay, it goes over the outside of the penis, but instead of it being enclosed at the end, it's connected to tubing that drains to a catheter bag. Okay, so it allows them to drain urine without having an invasive device. Now, if you have somebody who's been a spinal cord patient for a while, oftentimes they gain weight because they're not able to exert themselves as much. Not true for everybody. I mean, we've all seen the Paralympic wheelchair teams, right? They're pretty good health, pretty lean. But your average spinal cord patient gains weight, and then when they have this buildup of adipose tissue in the abdomen and lower pelvis, they can have some penile retraction. Makes it difficult to get a condom catheter to stay on. So you can put in a semi-rigid prosthetic that gives them a pseudo-erection permanently and makes it easier for them to keep those condom catheters on. That's the primary patient that you're going to see semi-rigid prosthetics in anymore these days. Otherwise, patients get these inflatable prosthetics. There are two companies that manufacture them primarily. AMS is one, and it was Boston Scientific, but they got bought. I can't remember what they call the combination company now. But the brand name for the non-AMS, for the other, Coloplast, that's who it is, AMS and Coloplast. So Coloplast, their clever marketing people decided to call their prosthetics the Titan. Titan series comes in different sizes. They all come in different sizes because they're individually sized for the patient, okay? And as you can see, there's a reservoir that's filled with saline, which is connected with tubing to the pump mechanism, which is placed in the scrotum. The reservoir is placed in the pelvis. And then it's all connected to the cylinders that go in the corporal bodies. And to use it, they just localize the pump in the scrotum, pump it up, saline goes from the reservoir into the cylinders, causes an erection, and it stays that way until they deflate it. Okay. In the earliest models, they had to actively pump the fluid out of the cylinders back into the reservoir. So half of the pump was squeezed to inflate. The other half of the pump was squeezed to pull the fluid back out. If you already have a patient who has poor manual dexterity, you can see where that would lead to fingers slipping and smashed testicles and things of that nature. So the newest ones have one-touch deflate. All they have to do is there's a deflate button that they click, and it opens a deflation mechanism, and just the pressure of the tissue around the cylinders pushes the fluid back into the reservoir. Here's a semi-rigid. That's what they look like. Okay. You can see they just bend it down when they're not using it, bend it straight when they are. Okay. Here's what prosthetic surgery looks like. There's great videos on YouTube if you're interested in seeing the placement of a penile prosthetic. There's a urologist here in San Antonio who pretty much exclusively does urologic implant surgery, and I don't mean just penile implants. He also does artificial urinary sphincters, which we'll talk about a little bit more in the urinary incontinence lecture. But just search Leroy Jones, Urology San Antonio, in YouTube, and you'll find operative videos if you want to see how this is done. One of the disadvantages of the inflatable penile prosthetic, which is an engineering problem, is they haven't yet figured out how to make a penile prosthetic that, in addition to increasing in diameter and rigidity, also increases in length. So one of the things that patients have to be counseled about when they have a penile prosthesis is you're gonna have an erection, but your erect penis is basically gonna be the same length as your flaccid penis. It does not get any longer with the inflation of the penile prosthetic because they just haven't figured out how to engineer that yet. They probably will, but they haven't yet. So they end up with some foreshortening of their erection. You cannot put a prosthesis in that is longer than the length of the corporal body. So what you see them doing in this picture here is they're both dilating the corporal bodies to actually push the spongy tissue out of the way, which is why patients who have penile prostheses can no longer have natural erections. Once they've had a prosthetic put in once, they're doomed to using a prosthetic for the rest of their life, which is why it's your last resort. But they're not just dilating the tissue, they're also measuring the length of the corporal body. You can't see it in this picture, but these dilators are demarcated. And then they also dilate the corporal body proximally where it goes underneath the pubic bone, back towards what's called the crura. And once they've taken the measurements, they know what length of prosthetic to put in. And you can't put one in longer than the corporal bodies, because if you do, it will erode. Just from the pressure of it being there, deflated. If it's too big, you can end up having the tip of the cylinder erode out the glands or out the urethra. I've seen that also. Okay. If they have vascular problems, they may need vascular reconstruction. You need a microvascular surgeon to do that. Most urologists don't do that. It's going to be a referral to a vascular surgeon. And it usually doesn't work. So if you have a person whose problem is trauma, and I mean physical trauma, not psychological trauma, they can attempt to correct the vascular problem, but it's usually not very successful. Some emerging technologies, shockwave therapy. The AUA considers it investigational. Okay, this is not FDA approved yet. It's in experimental phase, so I'm not even going to get into the details because it's not anything you can ask for. Intracavernosal stem cell injections. We're injecting stem cells all over the place now. Again, investigational. And platelet-rich plasma, which you've probably heard about in orthopedic applications. It's also used to do what they call vampire breast lifts, also not FDA approved. Okay. But we're starting to find additional uses for platelet-rich plasma. Maybe it will end up being effective for treating erectile dysfunction. We just don't know enough about these things at this time. None of them are approved. Okay. Here's some more information on shockwave therapy if you want to read about it. It's not going to be on the test. It's just for your knowledge. Okay. I've said this before. I'm going to say it again. Diagnosis of ED is a pivotal opportunity to discuss and address cardiovascular risk. Okay. Don't miss out on an opportunity to help a patient prevent themselves from having a heart attack or a stroke. If somebody talks to you about their ED and you determine that it is organic in nature, talk to them about their risk of cardiovascular disease. Okay? Talk to them about lifestyle modification, living healthy. All right, now a real quick note on premature ejaculation and we'll be done. Okay, so 2 minutes, like I said at the beginning, intravaginal latency. Lower limit of normal is 2 minutes. Okay. And your index patients are somebody who's had this problem lifelong versus somebody who has acquired it. Okay. And remember, this 2 minute number is subjective. It's based on the patient's background and it's based on their partner's level of satisfaction with their latency as well. Okay. There are standardized tools that you can use to evaluate somebody, so questionnaires. Usually these patients should be referred to a mental health professional, especially if it's acquired. But even lifelong, I mean, you can have somebody who had something catastrophic happen to them as a child, sexual abuse, something of that nature, and they've never been treated for it, never dealt with it, and it's resulted in them having premature ejaculation. All of these medications is off-label use for treatment of premature ejaculation, but they do work. Paroxetine is kind of the gold standard because in addition to addressing their premature ejaculation, it has minimal effect on erectile function. Okay? But any of these will work. And if you see a patient for premature ejaculation and you try these conservative management therapies and they fail, then refer them to us. Okay? Questions? All right. So, as I mentioned, on Thursday, we will cover urinary incontinence and infertility. And then on Friday, we'll have the exam review. Okay. A note on the infertility lecture, before I forget to say it, the standards that you're going to be tested on in regards to infertility are as they apply from the male perspective. Okay, so you're going to learn things about infertility. If you haven't yet, you're going to learn things about infertility and women's health, and the standards are different. So if you've already had some infertility lectures from Dr. Love, don't apply what you've learned in